Hi, my name is Mishra, and today I'm going to talk to you about this late-breaking work, Theory is in the Eye of the Beholder, Exploring Difficulties with Validating Intervention Mechanisms. When we create behavior change interventions, we make them in the expectation that they'll work a certain way, and that's called the mechanism of change. Different models of behavior change, like the theory of planned behavior or the health belief model, describe different mechanisms of change. And understanding what mechanism an intervention works through is important because the knowledge we gain about designing for specific mechanisms is what enables us to accumulate knowledge about designing for behavior change. And for this reason, there have been increasing calls in the HCI community for articulating and measuring our intended mechanisms in behavior change research. But how do we validate that the intervention works the way we intend it to? In particular, how do we know that the end user responds to the intervention the way researchers expect? What if the researcher thinks it's operating one way, but for the user it's actually operating through a different mechanism? We need to understand whether user responses to interventions align with expert predictions about how interventions work. Otherwise, we run the risk of not understanding the full picture of how an intervention is succeeding or failing. So we looked at this question in the context of a larger study exploring how to encourage hospitalized patients to speak up to clinicians when they have concerns about their care. We sought to create low-fidelity prototypes, encouraging patients to speak up based off the integrated behavioral model, and explore patient responses to those prototypes. So to do this, we did 3 studies, and I'll describe each of them in turn. Study 1 was a survey study asking 7 experts, defined as people with advanced degrees in HCI, behavioral science, or related fields. Hi, my name is Mishra, and today I'm going to map the low-fidelity prototypes we created onto mechanisms in the integrated behavioral model that influenced behavioral intention. And our goal is to validate that our prototypes would relate to specific mechanisms by achieving expert consensus on what prototypes acted through which mechanism. Sounds simple, right? Hi, my name is Mishra, and today What we actually found was really low consensus amongst experts, which we hadn't expected. And we also heard some feedback from participants that the survey had been really hard, so we just wanted to find out what was going on and make sure that our validation method was valid. So we did study 2. We interviewed some of our expert participants to understand what was going on and what their thought process had been in completing the survey. Hi, my name is Mishra, and today I'm going to found that experts sometimes mapped prototypes onto more than one mechanism when the prototype was too complex to operate through just one. So for example, a prototype designed to build self-efficacy by showing examples of other patients speaking up also operated through influencing people's beliefs about what other patients did. But that's a different mechanism from self-efficacy in the integrated behavioral model. In addition, we found that experts often had assumptions about the interrelations of different mechanisms. So, for instance, feeling that people's beliefs about what other patients do would influence self-efficacy. So those things together made expert consensus very difficult to achieve. We eventually assembled a set of prototypes using a simple majority instead of statistical agreement and did study 3. And that was taking these prototypes to hospitalized patients to explore what kinds of systems might be valuable to them. So we interviewed patients at 2 different hospital sites, including both adult and pediatric patients, and including the parents or caregivers of some of the pediatric patients. And we coded the transcripts using a codebook derived from the integrated behavioral model. We found that like experts, patients didn't always interpret the prototypes in the same way. They didn't always have consensus either. And moreover, patients and experts didn't always align in their interpretation of the prototypes. So for some prototypes that experts had agreed acted through one mechanism, patient responses illustrated that it could operate through another. So what does this mean? The question is which mechanism should be evaluated, the mechanism that researchers who create the behavior change intervention intend to target, or the mechanism that data from end users suggest may actually be in effect? Our findings show that these mechanisms may not be the same, and in addition, interventions with complex designs may unintentionally leverage more than one mechanism, or those mechanisms may actually be interrelated. So maybe instead of asking which mechanism should we evaluate, researchers should ask what possible mechanisms should we evaluate. And to do this, researchers should look at the whole of the theoretical model their intervention is based on. So for instance, if a researcher creates an intervention using the integrated behavioral model and decides to target self-efficacy, the researcher should also see if the intervention measures other mechanisms in the model, such as perceived control, beliefs about norms, and attitudes towards the behavior. There are obviously some limitations to this work. We had a small sample. We only studied one model, which means it's hard to say if our findings are just due to the problems of the model. But the findings still reveal something critical, which is that the way researchers think their intervention is operating may not line up with how it actually impacts users. To account for that, researchers should think about measuring outcomes using the whole theoretical model they're basing their intervention off of, not just the mechanism they're specifically targeting. Thanks to AHRQ for funding this work, our research sites and participants, and my wonderful collaborators.